I think there is 40 of us supposed to join, and till now there is only 50% of people over here. While I'll lay some ground rules for the session to go on is, first you have to tell me if I'm audible and is there any disturbance which you're hearing from our end. I want everyone to become extremely active on the chat box. This is not going to be one of those lectures where you will just listen and then the class gets over. I'm going to ask a lot of things and I want active participation. Until the time you answer or give your inputs, we are not going to move forward. Is that okay? Can we start using the chat box already? Yes. You can open the chat box and put it on this side for the time being. Okay, voice is clear. Out of 22, only 2 people have responded so far. What about others? All right. Haripriya, Lakshmanan. Yes, sir. Okay. Okay, more of you. Now, there is some work which is happening over here. Are you able to hear any disturbance? I want you to respond and tell us. Because over here it sounds it's loud. Is it loud or is it okay? Is there any disturbance which you are getting? Yes, please respond. All right. So if there is any disturbance happening anywhere, you please let us know so that we can may take a pause maybe at that point of time. Okay, next question. Are the slides visible? Yes, please. Are the slides visible? I want an active response.
Yes, doctor. It is visible.
All right. All right. So that brings us to the topic of delirium. So I want to ask you, what do you mean by the term delirium? When you have you heard the term delirium? Chat box, can we put it on the screen? Have you heard the term delirium? What does it mean to you? When you hear the term delirium, what does it mean? When you hear the term delirium? Yes, you can start becoming very active on the chat box. Till I get responses, we won't be going ahead. And I'm not able to see anyone other than one of you. Only one of you are ready to come online so that I can see you. Okay. Vigneshwari is saying acute confusion. Sister Lakshmi is saying serious disturbance in mental abilities. Yes. Only 2 responses out of 24. 24 people are attending. I think we should give attendance only to those who respond. And I think you know that your attendance is compulsory for your certification. Okay. Yes, more responses. What do you mean by the term delirium? When you hear the term delirium, have you all heard the term delirium or is it the first time? Disturbance in mental status, yes. There is acute confusion, there is serious disturbance in mental abilities, there is confusion, there is disturbance in mental status. Yes, more responses, please. Sister Minnie Elizabeth, Sister Mamta Murmu. Forgetfulness, okay. Cognitive impairment, yes. So the people who might taking the name, they are responding. I think I should take everybody's name then. Sister Mariama Jacob. Okay, cognitive impairment. Right. So let's look at this. So basically, delirium means it's a Latin term. It was first used in the year, it's nearly 400 years ago, it was used for the first time, the term delirium. And it means basically to go off track. That is, normally we want to go straight, but many a times we may tend to become, like you said, confused or cognitive impairment is there, or there is some confusion happening, there's a disturbance in mental status because of which we tend to go off track, right? So that is what delirium means, that is to go off track. So basically it is an acute confusional state. But let me ask you something. All of us tend to get confused once in a while, right? During doing many things. Can I have the mouse over here? Yeah. So many a times we get confused. Does that mean we are in delirium? Only Sister Haripriya is there whose video is on and I can see her. Nobody else I'm able to see, which makes me very sad. Is there more people who can become a little bit more interactive? Yes, Sister Margaret, hi. Sister Suraya, good to see you. Sister Lakshmi, yes, much better now. I can also have a smile, otherwise I'll go into delirium after some time of talking to myself. All right, somebody is driving, please be careful. All right, all of us get confused once in a while. Does that mean that we are having delirium? Yes, come to the chat box and respond, please. Okay, Sister Philomena, good evening to you too. Now let's get to answering the questions. All of us get confused once in a while. Does that mean we have delirium? Okay. Okay, no. Sister Haripriya says no. So when is it that we call it as delirium then? So we say that we are in delirium when it is associated, the acute confusional state is associated with a medical condition. There is an underlying medical condition, or there is an intoxication because of some drug or drink. These are two basic causes which cause intoxication. Or there is a substance withdrawal. The person was on drinks or on drugs and has stopped, and they are now they are in a state of withdrawal. That can also cause acute confusional state. Okay. So there are many reasons for it, but basically just remember this much. It is an acute confusional state associated with a medical condition or intoxication or with substance withdrawal. So what does confusion mean? Like you said, the way many of you have described in your chat box, confusion is a mental state and a behavioral state of reduced comprehension, coherence, and capacity to reason. That is, they are not able to understand what is happening in their surrounding. They are confused. They are not able to relate to what is happening around them. And if you go and talk to them and try giving them some reasons that no, maybe it is they are in the hospital, and you go and talk to them, and when you ask them where are they, they'll say they are at home. So you will tell them, no, you are in the hospital. Can't you see there are new people here? The kind of bed you are on, you can see this is a ward. There are nurses walking around. This is not home. This is a hospital. Even if you tell them, they will not believe you. So there is a decreased capacity in reasoning as well. So one thing I want you to remember is, usually what do you mean by the term acute? Yes, come to the chat box again. What do you mean by the term acute? I have time till 5 o'clock. So till the time nobody responds, I can wait. What do you know? What do you understand by the term acute? Come to the chat box and respond. Yes, Sister Margaret. What do you mean by the term acute? Sister Lakshmi, Sister Shirley Abraham. Okay, sudden onset and sudden cure. Okay, that is one way. Short period, yes. Less than 6 months or short duration. Okay, 6 months is a little too much long for acute. That would be something called as chronic. Sister Haripriya says condition which occurs less than 6 months. Could it be sudden? Yes. So what we usually mean is, what do you mean by an acute MI? Acute myocardial infarction, heart attack. When you hear that, can you wait for 6 months? I'm asking a question. When you're saying, few of you are saying 6 months and all.
It's becoming dangerous very quickly.
Yes, dangerous, then we have to treat it. And one of the things is, as far as delirium is concerned, remember this. Usually, when we say acute, we are talking about few minutes, usually, or maybe less than a day. That's what we mean by acute, the sudden onset, like many of you have said. But in delirium, acute may mean, it can mean few minutes or few hours, or it can mean few days also. That over the past few days, a person has become little abnormal in their behavior, or they are behaving confused. And what do you mean by the term prodromal symptoms? What do you mean by prodrome or prodromal symptoms? Yes, come to the chat box and respond. Or if somebody wants to unmute yourself, feel free to unmute also. Okay. Prodromal symptoms. Have you heard of the term prodromal symptoms? See, now let me ask you something. When you are going to get fever, you know, you know that tomorrow you may get fever. What starts happening today? Tomorrow or day after you may get fever. Okay. What do you start feeling today? Do you feel little uneasy? Do you feel little bit of restlessness, or some form of you start sweating a lot, or you feel little tired, fatigue is there in general?
Yes, sir.
Yes. Have you all started feel, do you feel like that? So when that
Yes.
starts happening, yes, exactly, Sister Suhani saying body ache. So it is before the actual onset of the issue, of the medical issue. Before that itself, there will be certain symptoms a person develops. So, like we said, for fever, usually we start feeling that there is, you feel tired, body ache, you don't feel like your mouth starts becoming dry, etc. Same way for delirium, that is this acute confusional state which develops. There are certain prodromal symptoms which can happen. And what are they? They are restlessness, irritability, and sleep disturbance. You will see that the person becomes very restless. If they are lying on the bed, they may just start maybe pulling the bed sheets, or they may look at you angrily. They may not be able to sleep at night, or sometimes just in the air, they'll just be trying to catch something and all in the air. Have you all noticed this, sisters, in the wards? Have you noticed people do these kind of things, that they are just trying to catch hold of something when you go to talk to them, or if you just observe them from a distance, they'll just be picking on their clothes, they'll be doing like this, or they'll be pulling the bed sheets, or something, they'll be trying to get hold of something. Have you seen? Yes, Sister Vigneshwari has seen, Sister Suhani has seen. Yes, everybody is working in a hospital side. Is there anybody who is working here in an NGO, and like a non-governmental organization, or another palliative care centers like that, or are all of you part of hospital? Can you just type in where do you work at the are you in a hospital, or are you in an NGO, or do you work in a hospice? Can you just type quickly one word, hospital? Okay, Sister Suhani is working at an NGO. Sister Surya is in pain clinic. Okay, good, good. Yes, I meant all of you. Yes, working in the hospital, hospital, hospital.
What about the hospice?
Yes, about hospice also. Sister Renuka, are you working in a hospice? Okay, fine. So you must have seen that there are people like this who have abnormal behavior, or their restlessness, irritability. And if they have a medical condition, you better be careful. You must alert your team that maybe this person is going in for a delirium. And there'll be a fluctuating course. Fluctuating course means many a times, when we were medical students, that time when we go and sit, talk to the patient separately in the morning before the main doctor comes, we'll go and talk to the patient, and the patient will give a certain history, and I will write down everything, taking 1 hour, 1.5 hours, I'll take and write down everything. Then when the main doctor comes and we have to present in front of the doctor, so when we are presenting and the doctor will ask, yes, did you say give this history? Then he will ask the patient, and the patient will say, no, sir, like that. Then you will be surprised, because you know that the doctor is going to take your case. right, later on. So what happens in a fluctuating course is, when you go in the morning, the person is normal. When you go in the afternoon, the person is abnormal. When you go in the evening, again the patient is normal. Maybe towards the night, the patient is abnormal. So there is a fluctuating course of normal and abnormal behaviors. Along with that, there is disorganized thinking, incoherent speech, reduced attention span, increased or decreased psychomotor activity. One thing I told you is that they may try picking on something on like clothes or on the bed sheets. So other thing is, they may simply be sitting as if they are in depression. That is, if you look at them, they will simply be sitting either staring somewhere and sitting unmoving. So you're not sure that what is happening to them. You will feel like they are just very stable people who are sitting. No issue is there. They are simply sitting like that. You may feel. So there can be decreased psychomotor activity as well. Then they can show a lot of aggression, emotional instability, anger, fear, etc. Agitation, noisy, aggressive behavior. They may harm the people who are nearby. So you have to be very careful with them. Altered perceptions, which is like hallucination. They may tell something like that there is somebody hiding under the bed, or somebody is waiting to harm them behind the curtain, or somebody is always staring at them, or they may say that their spouse is having an affair. These kind of things, lot of hallucinations they will be having, and they will all be expressing it. Yes, would anybody like to come and tell me some situation, some patient like this, who was having hallucination, and what they told, what the experience was of the patient? Can somebody come and share? You can unmute yourself and share also. Have you all seen cases of hallucinations in the ward?
Yes, doctor, I've experienced patient is shared their moment that they have seen little ants on the walls
Yeah.
hanging over, and they see some of them mention about the ghost.
Yes.
Some they
Yes.
mention children are playing around.
Yes. Exactly.
This is
Yes. So a lot of different kind of imaginations, whatever they're having. Is Sister Marceline has saying, seeing a lady in the red. Yes. So these are the situations. So all kinds of situations happen. Is it easy for the caregiver to see somebody near and dear? Okay, let's put ourselves. We have our very close people, our family members, or our very close friends are there. Imagine they are having some disease and they are lying down and they are undergoing some sort of hallucination. Is it easy for you to keep looking at it? Will you say that patient is having some symptom? Is that how you look at it, or is it going to impact you in some way? Yes, come to the
Yes,
chat
sir.
box. Yes, please. Yeah, please continue. Somebody was sharing.
It will be difficult to see our own people suffering from such kind of disease. It's
Yes,
not
yes,
easy.
yes. So it is difficult for our, when somebody of ours is lying over there, we may become, very sensitive to it. But when we are part of the health system, many a times we don't think in that way, right? We are like, okay, a patient is having hallucination or delirium. Now let's go tie the hands and legs. Have anyone of you done that, tying the hands and legs? Yes, please respond on the chat box. Has anyone of you done tying or of the hands and legs of the patient, because the patient is very difficult to manage? Okay, I've got 3 yeses so far. Yes, so it's a common practice, right? It's a common practice where we are asked to tie the hands and legs of the patient. But I want you to imagine, you are already restless and irritated right now due to whatever reason, and I have to control you. I have to make you calm. And my only way is that I will tie your hands and legs. Is it going to make you calmer, or is it going to make you more agitated? Please come to the chat box and respond. Is it going to make you calmer, or is it going to make you more agitated?
More agitated.
More agitated.
Definitely, right? What makes you think that if you go and tie the hands and legs of a patient who is already in this delirium state, that they are going to be okay and they're going to be more controllable? Right? This is something which we need to ask the medical doctor. That many a times this is what we do. But I want you to know that this will worsen the symptom of the patient. It is going to make it is going to make more difficult for you to manage it. Instead, we need to start them on certain medications, which we'll be seeing later. So is everyone with me till now? Yeah, is the pace of the class okay, slow? Is it too slow? Do you want me to go faster, or is it too fast and you want me to go slower? Give me a feedback so that I know, because anyways, you all are hiding behind the screens and 90% of you are not even showing me your faces. So I'm not sure what you all are doing. So tell me, you want it to go slower, faster? Is it okay? The same few people are responding. That means I know whom to give attendance to today. Okay. All right. So let's move on then. See, the hallmark of delirium is attention deficit. Okay. We will look later. Now, so many features I told you, despite of telling all these features, the hallmark, that is the main symptom of delirium, is attention deficit. That is, one moment they are saying something, the next moment they will say something else completely unrelated. This is what attention deficit means. We look at how we can measure attendance deficit. Okay. But first, let's look at the causes. So that it is easier for you to remember, we have categorized it as the term delirium itself. Okay. D means drugs. There are many drugs which will act as on the difference. See, what basically is happening in delirium is that in Hindi we say brain mein chemical locha hai. That is, inside the brain there is some chemical imbalance which is happening. So there are many drugs which a person can have, with which there is chemical imbalance in the neurotransmitters of the brain, or there is, very simply put, chemical imbalance in the brain. Here you can see on the left side there are a lot of these are called as neurotransmitters. Neurotransmitters are nothing but chemicals in the brain, in the nervous system. So all these are chemicals, okay, which is there in the nervous system, inside the brain and the spinal cord. And here you can see a list of drugs which act on these, which affects these chemicals inside the brain. So if your patient is on these things, okay, on these things, then you can assume that they can have an effect on the chemicals inside the brain. And here you can see that what is the effect on agitation. There are certain medications which will decrease the agitation. Agitation means the angry, aggressive behavior which the patient is showing. And there are certain medications which can increase the agitation also. So I want you to be aware that drugs can definitely cause delirium. Apart from this, remember that it is not always just the legal drugs. There are illegal drugs as well, which is very openly available in today's world. Those drugs can also cause delirium, or they can aggravate delirium, including drinks and drugs. Okay. Second is eyes and ears. How can eyes and ears cause delirium? Can one of you come to the chat box and tell me? Can something to do with the function of the eyes and ears, can it cause a confusional state? How can eyes and ears, something to do with the eyes and ears, cause a confusional state? Yes, who would like to unmute themselves and respond or add to the chat box? Okay, cataract.
Hearing impairment.
Staring look, sir.
Okay, staring look.
Loss of hearing.
Loss of hearing.
Yes,
Okay.
that may be the hallucinations, no?
Hallucination is possible even if the eyes and ears are working properly.
Yes.
So can I tell you?
Hearing impairment.
Yes, hearing impairment. So let me ask you something. Suppose there is a sudden bomb blast. Okay, let us hope it doesn't happen anywhere. But suppose suddenly outside the building there is a bomb blast happening. What will happen suddenly? What will happen to you? You will be confused for the first 1 or 2 minutes. What has happened? What just happened? Right? Same way, yeah, you'll be in shock and you'll be so confused. Same way, you are walking around in a hall full of people, and suddenly the lights go out. Suddenly the lights go out. What will happen? Will you be confused? Some people may be happy that the lights go out so that they can do some mischievous activities like we used to do in school, shouting and howling and all. But otherwise, when the lights go out, suddenly we become very confused, right? Suddenly we are not sure what is happening. So same way, I want you to imagine elderly people who are across 60 years of age, and slowly the hearing and the vision apparatus has become decreased in function. So when that happens, what will happen? Along with that, when their medical condition, underlying medical condition which is there, it may aggravate the underlying medical condition and cause confusion in the person, because they are not able to see clearly what is happening around them. They are not able to hear properly what's happening around them. So throughout their life, for 60 years, majority part of their life, they have depended on the hearing and eyesight to do day-to-day activities. When it stops functioning like before, there is an element of acute confusional state it can contribute to. Can all of us function without oxygen? Or can any one of us function without oxygen? I'm sure the answer to that will be no. So whenever there is a low oxygen state, that is, if the low oxygen state happens to your heart, we call this a heart attack. When it happens to your brain, we call this a stroke. When it happens inside your lung, we call this pulmonary embolism. So all these things can happen. So whenever there is a low oxygen state, eyes infection. Infection causes inflammation. And when inflammation happens, there are certain inflammatory mediators, again chemical substances, which is released into the bloodstream. From that bloodstream, it will go to the central nervous system and it will inflame the central nervous system also. It is called as neuroinflammation. And when your nervous system itself is inflamed, that means you are not able to perceive properly what is happening around you. Again, it will lead to infections. So remember, uncontrolled infections can lead to delirium. Very important in the palliative care setting, R is for retention of urine and stool. Remember this one thing, whenever there is an acute confusional state, we always go and ask whether the person passed stools or the person has passed urine or not, because it irritates the nervous system. It irritates the nervous system and it can again trigger delirium. So retention. Many a times the person may be having delirium and you are talking to the family and you have to tell, so the family will ask you, what is the treatment, sir? And then I will say that we are going to give enema. So the caregivers will be confused. The problem is in the brain and you are putting enema from down. What is this? Where is the problem? Where is the treatment? So this is one of the reasons, that because the retention of urine or stool. Post-ictal states after seizure, there can be confusion. In palliative care setting, many patients having cancer, remember, uncontrolled pain can be a reason for delirium. So always, even though there may be delirium, what we choose to do may be give pain medications. So uncontrolled pain. M is metabolic. If your kidney failure, liver failure, there can be a lot of metabolic abnormalities. Even glucose, if your glucose becomes too low or too high, there can be delirium. And subdural hematomas, which is basically collection of blood inside your skull due to some accident or even due to falls in the elderly. So know about the burden of delirium. Nearly 30% of patients who are hospitalized have delirium, and especially towards the end of life care, there can be nearly 85% of patients can have delirium. Yes, Sister Vigneshwari, ictal means something to do with seizures or fits. So, many a times when patient gets fits, immediately after that, the person will be very confused. They are not sure where they are, what happened. Sometimes they pass stools and urine also. in that state of when the fits is happening or immediately after that. So these are the things. So post-ictal confusional state it is called as. So after the seizure has happened, the person can get some confusion, can go into some confusional state. So that is what it is. So burden of delirium is 30% of hospitalized patients are prone to have delirium, and about 85% of patients towards the end of life, that is the last few hours or last few days of life, a person may have delirium. What happens? What is the problem if there is delirium? There is a functional decline. That is, elderly people out of this confusion, or they are not able to see and they are not able to understand what is happening around them, they may tend to fall. If they tend to fall, there is a fracture. If there is a fracture, you will tell, stop moving. Right? See, when we were all in school or in college, many of us were athletes. How many of you were athletes or involved in some sports activity during college times or school time? Yes, please. You can raise your hand or you can come to the chat box and respond. Respond with the sport which you are involved with. For those who were involved with some kind of sports during your school or during college life, now everybody is working and having family and everybody is busy. But those of you who are involved with some sports, can you come to the chat box and just tell me that what sports you were in? Okay, you are into running, Sister Vigneshwari. Okay, others? Out of 31 people, only one person was involved in sports. Rest all were having sedentary lifestyle from school.
Badminton.
Right. So I've got 2 badminton players, 1 ring ball player, 1 runner. Okay, Sister Margaret, badminton. So you have seen that when we used to be involved with some kind of activity, sports and all, running and long jump. Yes, we have so many sports people with us who have taken up nursing as careers. So when we were actively involved, right, our muscles were also active all the time. But slowly, as we have become, our work has become, we have started working. Then once you go home, either you are tired or you have to take care of your family. Have you seen your physical capacity has started becoming lesser? Maybe the muscles have started becoming little smaller. Yes, Sister Philo Isapan was into skipping. Sister Lacey was into running again. I'm also into running and table tennis. Okay, so what happens is when you start getting immobilized in some way, okay, what will happen is there is a decline in your activity. When there is a decline in the activity, your muscles will also start becoming less and less. So it is called as disuse atrophy, right? So overall, there will be something called as a functional decline. So once there is a functional decline, the patient falls, there are fractures, there is immobilization. Again, it will lead to functional decline. So it is like a vicious cycle. When a person is in abnormal state, most of the time they are not going to pay attention to their hydration and nutrition. The family members may want to go and feed them, but then they will say, no need, I don't want. And sometimes they may throw the water or throw the food, even if you go and give it to them. And this will be a very big emotional burden for the family to see that somebody whom they love is like lying down all the time, not eating food. They are shouting at you. They are telling that, their children are mad. They are telling that, all kinds of things. So very big emotional burden also, right? So this is the impact of delirium, which I don't want you to forget. For us, it may just be a symptom a patient is having, go tie their hands and legs. But think of the patient as well as the caregivers. There are so many things which they are going through, and we have to see how we can support them. So why delirium happens? Yes, there are a lot of reasons for it, but there are so many reasons because it is still unclear. The pathophysiology is yet poorly understood exactly how it happens. But basically, it is because of 2 reasons. You can see the third last and the second last point, either deficiency of acetylcholine or excess of dopamine. Okay. So can Sister G's tell me which is that one disease, very common neurological disease in which dopamine is affected? Yes, Sister G's. One disease in which dopamine is affected, very common neurological disease. Not really blood pressure, no. It's a neurological disease. Yes, Sister Haripriya, it is Parkinson's disease. But remember one thing, that not all individuals who are exposed to the same insult will develop signs of delirium. For example, if my boss comes and shouts at me, maybe I will not get affected at all. But if my boss comes and shouts at my colleague, he may feel bad about it or he may get angry about it also. So not all individuals exposed to the same insult will have the same reaction, right? So let's look at that. What is it exactly? See, on this side, one side you have individual risk factors. On the other side, there are triggering factors. If your individual risk factor is low, okay, for example, young age, I don't have any other chronic diseases, I don't have any dementia. So that means my individual risk factor is low. For a person like me, in whom individual risk factors are low, something very bad has to happen for me to go into delirium. Can more of you switch on your videos so that I can have a look at you? Only Sister Ruth and Sister Haripriya are there. I'm getting bored looking only at two people and at myself also. Oh wow, so many have come suddenly online. See, you could have done this before itself, right? Why you are making me say this again and again? So whenever the individual risk factors is low, something really bad has to happen, right? When we are very happy and everything seems normal, something really bad has to happen. Only then we will get affected by it. So for example, some small infection was there which became a full sepsis. It went through the bloodstream and then it became a sepsis. Or there was high risk surgical procedure like a neurosurgery, it was done. Something happened and then I underwent a neurosurgery and I'm taking so much time to recover, or some major surgery, or there was some drug toxicity which occurred. So I took just one tablet, but I'm completely gone. Something was wrong in the tablet. So some sort of a drug toxicity, right? These are the causes which will cause delirium. But some people may have high individual risk factors. You can look over here, down. They have got high individual risk factors. That means they are elderly age group. They already have diabetes, hypertension, some other diseases they already have of the brain or of the kidneys or of the liver. They are having dementia also. So that is memory loss is also there. So in such people, something very small only needs to happen. Like I said, when they have all these high individual risk factors, if they lose their vision or if they start losing their hearing, even that little bit, if it starts getting affected, then they can go in for delirium, right? So understand that all of us are at risk of delirium. Any one of us can get, but something very big has to happen to us probably. But for a person who already has high individual risk factors, something small can also be a trigger, right? So there are certain situations where delirium threshold is lower. That is, easily they can get delirium. That is extremes of age group, or if they're having memory loss, if there is vision or hearing impairment, if they're abusing alcohol, if they're having some depression, if there is reduced physical activity. You know, elderly people, many times we say, right, don't go out of the house, don't do this, don't do that. We keep telling elderly, right, because we get irritated. So even something like that, because of which there is reduced physical activity, they can go in for a delirium. Is everyone with me till now? Come to the chat box and respond. How are you all able to follow the class? Are you able to understand? Is there something you want to ask at this point?
Yeah, doctor, excuse me, doctor. Just I have a doubt. Is the patient who are having Parkinson disease, Will possibilities have a delirium, doctor?
Yes, Sister G. So when a person is having Parkinson's disease, already they are having some neurological issue. There are some chemical changes in the brain. Now, along with that, like we said over here, like you can see in this slide, which is the next slide, if there is any triggering factors for delirium, then that such a person can easily go in for delirium. What are these triggering factors? See, many of us have the dream. How many of you had a dream like you want to gift a new house to your parents, or you want to build a new house of your home of your own, and you want to invite your parents to stay there as a as a gift or as a surprise? How many of you have such desire or have had in the past such a desire? For your parents or elderly people, you want to build a new house, you want them to come and stay there happily ever after. Okay, two sisters have. Right, more of you have. So now imagine your parents like that, they have got some diabetes, hypertension, or they got vision problem and something and all is there, or let's say they have got Parkinson's. Now you very happily you built a new house. Okay, you work for 10-20 years, you built a new house, and then you are going to surprise your parents. So you will tie one blindfold to them, tell them to close their eyes, and you will take them in the car and you will take them to your new house, and then you will open. Once you will open their eyes and they are seeing that this is a new place, now you are expecting them to be so happy for you, but instead what happens? They get fully confused. They get agitated, they get angry, some of them go into depression. Now you are wondering what is their problem? The problem is they already had some underlying disease. So there were people having high individual risk factor. With high individual risk factor, you have taken them to a new environment, a change in environment, and you are telling them to stay there. So now they are in unfamiliar surroundings. When they are in unfamiliar surrounding, they will be in acute confusional state, right? Unfamiliar excessive stimuli, suddenly there is a loud noise, or light is not there, or too much light is there. If there is an unfamiliar excessive stimuli, general deterioration of their condition, like we said earlier, any of the uncontrolled symptoms, if there are brain tumors, something called as paraneoplastic syndrome, in which because of cancer, certain chemical mediators are left into the bloodstream, biochemical disturbances or drug induced. So these are all the triggers for delirium. So what are the types of delirium? If you look at the types of delirium, one is the person is very hyperactive. Next is the person is hypoactive, that is they are less active. Third is they are mixed. See, you can look over here, this line in the center, the pink line in the center, this is the normal state. And you can see that this green line above, when it goes above, the person is more agitated. When it is below, the person is something in depression. Then again above, again depression, again hyperactive, again depression. When both of these happen, it is called as mixed delirium. So so these are the three types of delirium: hyperactive, hypoactive, and mixed delirium. Now I want our dear nurses to come online, come to the chat box and tell me, what do you want your patient to have? Do you want him to have hyperactive delirium? Do you want them to have hypoactive delirium? Or do you want him to have mixed delirium? Please tell me. And come to the chat box and post. What kind of delirium do you want your patient to have? Two people have chosen hypoactive delirium. I think because They want to have their patient to be not bothering them during their duty, because hypoactive delirium will simply sit at one place. But I think Sister Ruth, Sister Margaret, and Sister Sri Lakshmi, they want, if they sit hypoactive, it will be little boring. So in between, they should get hyperactive also. And then they should get, okay, don't want any delirium. Yes, Sister Karabi, Curtis, yes. Ideally, no. But let us say that, the person will anyways end up getting a delirium. In that case, Sister Sugna says hyperactive. Why, Sister Sugna, you want hyperactive delirium? Tell me. Can you unmute yourself and tell me why do you want hyperactive delirium? Sister Sugna Prabhavati.
The patients will affecting from the hyper will come.
Okay, so you're saying most likely it is a hyperactive delirium which you see. Okay, Sister Vigneshwari says hyperactive, you can easily detect symptoms and treat. Exactly. So this is what I wanted to highlight. Hyperactive delirium, you can see what is happening, because either the patient will take a glass and throw at you, or at the person who is sleeping beside them. So you will have to do something about it. But people with hypoactive delirium, they may not create any issue. So you may not tend to intervene. So what I want you to know is that people with hypoactive delirium, as time progresses, will have extremely uncontrolled symptoms or agitation, or the terminal delirium, that is towards end of life. We said towards end of life, 85% of patients will have delirium. At that time, it will be very hard and distressing to control the symptom if you have not started treating them from the beginning. It is like saying, when some small infection had happened, if you would have taken care of it, okay, that infection could have subsided, but you didn't take care of it. So the infection started spreading, and it became a sepsis, full-blown sepsis the person is having now. Now you have to admit the person in ICU, and you have to take care of them, with a high level of medications and everything. Similarly, hyperactive delirium, if you don't treat from the beginning, you will have to, it will become very difficult to treat later on. So let's move on. There are a lot of assessment tools. Like you can see over here, there are a lot of assessment tools for assessing delirium, but we will be looking at two of them. One of them is confusion assessment method, or CAM method. What do we do over here? Here, we want them to have at least two features. There are total 4 features. Out of these 4 features, we want them to have at least 2 features, right? The first feature is it is acute onset or fluctuating course. That is, it started within a few hours or a few days, and it has a fluctuating course. Sometimes the person is normal, sometimes he is abnormal. Second is there is inattention. I told you a lot of features of delirium we said, but the hallmark feature is inattention or attention deficit. Along with these two, there can either be disorganized thinking or an altered level of consciousness. Let us look at what each of these is. So acute onset and fluctuating course, you have understood. Inattention. How do you assess inattention? This is how you assess inattention. Either you can say, you can tell them 1, 2, 3 and tell them to say backwards. So they should be able to say 3, 2, 1. Okay. Or else you will say 5, 7, 9, 10. So they should be able to say in return 10, 9, 7, 5, like that. They should be able to say in reverse order. Or you can tell them from Monday to Sunday, if you are able to tell, say from Sunday backwards to Monday. Or you say that the years, January, February, March, like that. Instead of saying in the usual order, you tell it in the reverse fashion. They should be able to say that. If they are not able to say that, that means they are in inattention. Disorganized thinking, you ask them that, which year is it? Current year, which is the current day, or which month is it? Or ask them where are they right now? Are they in home or in hospital, etc. Altered level of consciousness, sometimes you can look at them, they'll be looking at you like this with eyes open, they'll be looking. That is, they'll be too much alert or vigilant. Or sometimes they'll be lethargic, or sometimes they'll be sleeping, sometimes they'll be normal, sometimes they'll be in comatose state. So different levels of altered consciousness. One of the other methods of knowing this is something called as the 480 method, 4 assessment test for delirium and cognitive impairment. In this also, we are trying to assess the same thing, but there is a scoring for it. For example, alertness. If alertness is normal, the score is 0. If the alertness is clearly abnormal, the score is 4. And if the score reaches 4, that means the person is in delirium. So same way, there is age, date of birth, and place, and the current year. If they are able to answer all these 4, that means no mistakes. So no mistakes means 0 marks. But if they make mistakes, we'll give them 2 marks. Like that, you have to add it. And if the scores is more than 4 in total, over here, if you get the total score as more than 4, that means the person is having delirium. Now coming to management of delirium. First thing, as we already saw, that there are so many causes of delirium. So whatever is the basic cause of delirium, you have to make sure that you are correcting the correctable. That is, whatever correctable causes are there, you have to correct it. It may be giving antibiotics for an infection. It may be giving painkillers for pain. It may be giving an enema for relieving the retention of the stools, or it may be putting a catheter to make sure that the urine is drained. Sister Ji, I am just asking out of curiosity. Can you come to the chat box and tell me, a person is having retention of urine. What is one of the commonest causes of retention of urine? The person says, I have not passed urine since morning. What is one of the commonest causes of retention of urine? Yes.
So urinary tract infection.
Urinary tract infection, yes, more often, but then they will be saying that I'm having burning sensation while urinating. So that is a common thing. Yes, infection can cause, but not likely to cause complete, this thing, unless there is a lot of pus or something which is blocking. Dehydration, no, even no matter how dehydrated you are, at least in dark yellow color, some urine will come.
Blockage.
Sister Suraya, I didn't hear you.
So blockage of the catheter?
Blockage of the
Catheter, urinary catheter.
catheter. No, the catheter is not there. Suppose you have not put the catheter yet. What is one of the commonest cause of blockage by stone? Okay, but then the person will be having severe pain. Blockage by stone also, they will, until and unless both sides have got a stone which is stuck on the ureter, you will still get urine. Less intake of water, still will have urine. So I'll tell you, constipation. When the person is having a loaded rectum, that is, the rectum is full of stools, right? And that time, that rectum the stools which is there behind, it will impinge on the urethra and block the urethra from the back side. That is how the urine will not go. So many a times the treatment for urinary retention, you should always ask, when did the patient pass stools? Is he having constipation? You may have to do a digital rectal examination, put a finger inside and see that if there is some hard stone-like stool sitting over there. And many a times the treatment may be just giving an enema instead of putting a urinary catheter. So putting an enema, the person will pass stools also, and along with that, he will pass urine also. So always remember this. Okay. So always correct the correctable. The second thing is non-pharmacological. Always non-pharmacological management is what we should give preference to. Only after that you will go for drugs. I want you to know there are certain mimickers of delirium. See, like I told you, hyperactive delirium, you may look at the person and you may feel like the person is depressed. So how do we know whether the person is in depression or in delirium? Yes, anyone? The person is having hyperactive delirium, person looks depressed. So you will think that the person is having depression. Your treatment of depression is different, treatment of delirium is different. How will you know whether the person is in depression? Anyone?
Depression patients sometimes very They will be very quiet. They won't be sharing or talking. They won't be
It's the
eating.
same hypoactive delirium also is the same. They won't be talking, they will not be sharing much. They'll simply be sitting, not bothering anybody. So one thing is, depression usually will have a history, that there will be some triggering factor, and it has been happening since quite some period of time. We already told that hypoactive delirium means the first criteria is acute confusion state, right? So there may not be an underlying condition in depression, and it may be there for quite a long period of time compared to an acute onset. Other thing is, depression in a patient who is having delirium, we told that there may be fluctuating, there may be normal in the morning, there may be abnormal in the afternoon. But depression patient will be constantly like that they won't have any arousal issues. Like we said, right? They can be lethargic, they can be stuporous, they can be agitated, they can be multiple levels of consciousness or altered change in mental status. So those things are a little bit more stable in depression. So yes, there are other mimickers of this thing. Just know that there are different mimickers of delirium, and they are called as dementia, depression, or psychosis, right? Let us look at what are the non-pharmacological management. Sister G's, all the non-pharmacological management is something which you can do, and only you can do. The doctor can tell and go, but you will be the one who will be doing it. Now, one is, we'll go through each one of this, okay, because this is important for you. Optimize the sleep-wake pattern. You come and tell the doctor that, doctor, this patient is not sleeping at night time. In the morning only the person is sleeping. So night time it is irritating for us. You complain to the doctor. Okay. What may be the reason why the person is not able to sleep? One thing is, many of these patients who are in the ICU are usually prone for delirium. So in ICU, the lights are always on, the monitor sounds are always on, the doctors and the nurses are always chit-chatting. How do you expect the person to sleep at night? Even we won't be able to sleep in such an atmosphere, right? So one thing is that we have to optimize their sleep-wake pattern. By optimization means you have to help them. Why is it that we are able to sleep well with dark lights? Because when the lights shut out, that is when a chemical called as melatonin is secreted in the brain. And when melatonin is secreted, that is when you feel sleepy. So that is why when such patients come in delirium, one of the first things which we do is we will give them a window side bed, so that from the window they can see that there is sunlight. So, daytime increased exposure to sunlight, and at night time when the natural light and everything is switched off, that time they can sleep well. Maintain a low level of light and noise. Now, there are many private ICUs. You have seen private ICUs, private room ICUs and all are there, so that all these things can be done for them on an individual basis. Next is, there are certain sleep protocols which we can follow. That is, give them a massage. That it's not you as a nurse, you will have to tell the caregiver. You have to ask the caregiver, what is it that the person used to like to do before sleeping? So they will say that they have warm milk, or they want to have a massage to their head, or they want to listen to some kind of a music, something like that they like to do. So that is their sleep protocol. So you have to see that what is a sleep protocol for the person and facilitate that sleep protocol inside through the caregiver. Okay, you will have to be the one who advises this to the caregiver. Next is patient orientation. That is, you have to reorient the person. Again and again, you have to say that, daddy, you are in, whatever you call the patient, you are in a hospital right now. I am your nurse or I am your doctor. You are here for treatment or something like that. You have to repeatedly reorient the person. Explain where they are, who you are, what you are doing. Many a times what we do is there can be a whiteboard. A whiteboard is there, and that whiteboard you have to write on it that what they are doing, or where the person is, what the person's name is, what the person's family member's name is, which year it is. All this they can write so that every time they look at the board, they are reminded of it and they are reoriented. Okay. And there is a visible clock so that they can look at the time. If you don't have a whiteboard, what you can do, anybody, how you can write down something somewhere to remind the person? Yes. Any ideas? Especially people who like to see a lot of movies. Have you got any idea from any movie how a person can reorient themselves about who they are, where they are from, what they are doing? Any movie you all have seen? No, none of the sisters have time to watch movies. Write on mahjong paper. I don't understand what is mahjong paper, Sister Ji. Oh my God. All sisters are so hardworking that even once in a month they don't go to see a movie. These days Netflix is there, Amazon Prime is there, Z5 is there. So many applications are there. YouTube also is there. Still nobody is seeing movies, I think. That is very bad. Okay, so I will give you an idea what you can do. One thing which you can do is what Amir Khan did. Right? He wrote all over his body and he was reminding himself because he was having attention deficit. So every time he had attention deficit, he will look himself in the mirror and he will get reminded. Don't do this to your patient, otherwise tomorrow patient will come, patient caregivers will come and break your hospital and break your bones also. Okay, so don't do that, but whiteboard we can use to write. Right. Then next is communication. Ensure that the person is able to communicate with you well. That is, if they are not able to see, like one of you had mentioned, cataract can be a reason in the elderly. They have to undergo treatment for the cataract, or at least you can get them a eyeglasses, or you get them a hearing aid. They are not able to talk well because denture is not there. They lose their teeth. All of us will be losing our teeth one day and we will be talking like this, right? Without not this clearly, we'll be saying bah, 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 like that we'll be doing. So all of us are moving in that direction. That time we will tell our children, please buy dentures and give so that I can have a smile like I used to have when I was 30 years old. So dentures you have to give for them so that communication is good and there is good sensory stimulation. Okay. Encourage mobility. Many a times you tell these people don't move and you will tie down the person's hands and legs. All these things you may try doing, but we have already looked at it. If you don't encourage mobility, there will be some amount of disuse of the muscles. The muscles will shrink, the strength will shrink, and it will be a vicious cycle where the person will decline functionally. At least small things you should tell them, like, don't sit on the bed and have food. Make them sit on a chair, or at least sit up and give them a table on which they can have the meal. Avoid using physical restraints as much as possible. Treat the delirium with pharmacological management as far as possible. Whenever the person comes to such an extent that you have to tie their hands and legs, you treat the delirium with pharmacological management. Okay. And next is minimize use of catheter. Why? Because once you put catheter, the person is not able to move around. If the person is not able to move around, they'll be lying down all the time. If they are lying down all the time, there will be functional decline. Other reason is there is a chance of infection happening. So already infection will add to the delirium, right? Monitor bowel and bladder function. Always remember, doctors also hardly ask this. Did you pass stools today morning? Is a very important question to ask. Did you pass urine today morning? Is a very important question to ask. If not, you may have to look into the reason, or you may have to put a finger, do a rectal examination and see if there is fecal impaction, and then give an enema or manual evacuation so that there is a evacuation of the stools and urine. Always provide support and education to the family. Imagine, we already looked at this. If our family member or friend is lying down over there who is having delirium, it is not going to be easy for us to just accept it. We say, certain times we tell, yeah, they have to accept it is there. That patient is having these issues, they have to accept. Why will they accept it when you won't be able to accept it for your own family or your friend? So Always involve the family, tell them what the medical issue is, educate them about the medical issue and tell them that the person will behave abnormally. It will be like this for some time. We will take care of the person as well as we will do the necessary treatment. The person will become fine soon. Do not worry. Reassure the patient also in a calm voice. Tell the caregiver also not to get angry on the patient because the patient is not doing so purposefully. He is unknowingly doing it because of the medical condition which is there. So always provide support and education. Coming to the last part, pharmacological management. There are 4 situations where you have to go for pharmacological management. The one is you tried all the non-pharmacological management which we talked about. It didn't work. Next is the person is distressed. Third is the person is a risk for themselves or to others. They may harm themselves with some sharp object or they may harm somebody near them. Or they are in agitation. They are very irritated and angry. Any of these 4 situations are there, you have to give. But basically 2 target symptoms. One is agitation because if they get agitated, they may harm themselves or the others. And then next is perceptual disturbance. That is they are having hallucination. Somebody is standing over there and watching me. Somebody is hiding below my bed and coming to stab me. Or somebody is sitting and staring at me. Something like that. Perceptual disturbance if it is there. These are the 2 basic target symptoms for which you have to do treatment. What is the drug of choice? The drug of choice is something called as haloperidol. These aspects the doctors will look into, but you can be aware that haloperidol is the drug of choice for treating delirium. It is an antipsychotic. See, mind you again, what was the first rule of delirium for management of delirium? Yes, somebody, can you come to the chat box and tell me what is the first rule of management of delirium? Yes, already forgot. Are all of you gone into delirium? Okay. Yes, Sister Ji. Fix the fixable first. That is correct the correctable. Okay. Whenever something can be corrected, you correct it. Now you tried all those things and still it is not working. Now you are going to give a antipsychotic. See, but I'll tell you, most of the time all this goes hand in hand. You know, it is not like till the time you correct the, suppose correcting the correctable may be through a surgery. Okay, so till the time the surgery happens 3 days later, will you tell, let the patient be suffering in this distress, no problem, right? It is not like that. So many a times everything goes hand in hand, that you may have to give some medication. There are certain non-pharmacological interventions which you may have to do. And there is always correct the correctable, which you are discussing actively. So haloperidol is the drug of choice, which is an antipsychotic. Sometimes you may have to give benzodiazepine so that if the patient is too agitated or aggressive, you know, for hyperactive delirium, of course you will give haloperidol, but along with that you may have to give a small dose of benzodiazepine so that the person becomes less active or less harmful to himself and to others. So benzodiazepines also are used, but only for hyperactive delirium, and that is along with the treatment for along with haloperidol. So you can see all these are drugs which are used for treatment of delirium. There is haloperidol. There is the second one is not available here. There is chlorpromazine. There is olanzapine. There is quetiapine. There is risperidone. There is aripiprazole. So all these are medications which is used for treatment of delirium. All of them have certain side effects also. But you have to look at which side effect can be beneficial. For example, quetiapine over here causes sedation. And now we said that the person is having reverse sleep-wake cycle. That is, they are staying awake at night and sleeping during the day. So you want the patient to sleep at night. So instead of giving some sleeping pills, you can give quetiapine. It will take care of the delirium and at the same time, it will cause some sedation so that the person can sleep. So some medications you can use its side effects also. It can be useful, but you have to be aware of certain side effects so that you can avoid it in certain patients. So what is it finally? Always correct the correctable. Secondly, go for non-pharmacological management as far as possible. Many a times a multidisciplinary approach may be needed. That is, one doctor may not be able to decide what to do. He may have to take a surgeon opinion. He may have to take a nephrology opinion. Different people. So multidisciplinary team is needed. Always communicate and take the caregivers along. Okay. And lastly, identify the hypoactive delirium and treat it. Otherwise, the patient is going to have a very bad time in the future, and you will also have that bad time because the patient is going to come back to you. Right? So, yes, any questions which you have, please, I'll listen now rather than talking. Feel free to use the chat box for either questions or your comments or your thoughts or your suggestions, something you should tell. So either on the chat box or you can raise your hand and unmute yourself.
Can you give a small brief about the delirium and what is the difference of delirium and depression?
Yes. So we were telling that delirium and depression. How did my slide go? Oh, it got switched off. Okay. So it's here only, no? Why is the slide? Yeah. So delirium and depression is one thing we know that depression will have a certain background to it, right? There was some triggering element. Either some life situation happened or some situation in their life happened after which they have started going into a depressive phase. That is one thing. Usually the chronicity, the depression happens over a period of time. We said that in delirium, it happens acutely. Acutely means there is an underlying medical condition. Which are the causes? We looked at it. Delirium was the causes, right? We have looked at all the causes of delirium. It underlying those medical causes, if there is a trigger, then it can cause delirium, usually in an acute phase. But in depression, usually it will be there for a few weeks to a few months. The depression would have been there. And also in delirium, there will be the consciousness of the person can differ. Sometimes they can be sleepy, sometimes they'll be very alert, sometimes they'll be stuporous. So different kinds of consciousness. But as far as delirium is, depression is concerned, they will always be conscious. They don't have this hyper, they may become very vigilant and then they may become depressed. It's not like that. They're constantly like that. So these are some of the differentiating factors for depression. Of course, if you take an opinion from a psychiatrist, they will do a further detailed evaluation with the help of certain tools to assess depression, whether depression is there or not. Give me the mouse.
Okay. Thank you, doctor. Thank you.
Okay, Sister Ji. Yes, anybody else? Nobody's putting anything on the chat box. The comments which you cannot tell me directly, you can put on the chat box, no problem.
Doctor, can I explain a bit on this medication, levomethroxam?
Levomethroxam, yeah. So this is one medication which we do not have in India actually. In fact, I personally, we don't have any experience in using that. Also because the first choice of medicine is haloperidol. Because haloperidol is in the dosage, you can adjust the doses to a larger range of dosage adjustment can be done. It is easily available. Side effects is slightly lesser than the other medications. One of the problems with haloperidol is you see this extrapyramidal side effects. Extrapyramidal side effect would mean that what we see in Parkinson's is a extrapyramidal side effect. That is, in Parkinson's, the patient are having tremors, shaking of their hands and legs and feet. So these things happen. Those side effects are called as extrapyramidal side effects. That is because of decreased dopamine. And when you are seeing, when you're giving haloperidol, it may happen that they may get that extrapyramidal side effect just because of the haloperidol drug itself. Now you look in this slide and you can tell me over here, see, extrapyramidal side effects is maximum with haloperidol. But look at what are the side effects of levomepromazine. That is, there is sedation, so much of sedation. There is so much of hypotension and dizziness. Extrapyramidal side effects can happen and anticholinergic effects can also happen. That means that that is not at all a good drug to give. So many things can happen. You give this person this drug, while they may not be able to walk properly, they may fall. Already we were telling that we don't want them to fall and it may cause fracture and functional decline. So all these things can already happen. So that is why we don't have it over here also, and we don't prefer to give that also, even if you have, because there are better drugs with lesser side effect profile. Yes.
Thank
Yes.
you, Doctor. Thank you. Understand.
Okay, Sister G. Yes, anybody else? Questions? We can wait for one more minute. If anybody of you want to share something, you can unmute yourself, or if you want to add some comments to the chat box or give some feedback on the chat box, I will be happy to look at the chats. Is the patient with delirium will have restless condition too? Restlessness can be one of the symptoms of delirium. So they can have restlessness. Yes, it is one of the cardinal features, one of the features of delirium. But you have to see, you may have to see that do they have an underlying condition or not also. And then you may have to choose the treatment. They may be in psychosis also. In psychosis, it's a different diagnosis. So if they are having psychosis, then it is not delirium. You may have to differentiate it between psychosis. And then you may need a psychiatrist evaluation also for treating psychosis, because the medicines which are used is different. Yes, Sister Georgina, are you saying something? So these slides will be shared with you. Don't worry. You can have a look at the slides later on. And if nothing is there, then we shall end the session.
They can eat properly, delirium patient.
So delirium patients, that's what they won't eat properly. So you have to, there are times when, they will just throw the food at you, or they may take the water and they will just throw it on your face itself. These kind of things may happen. So that is why in such cases where they are not, their routine function is also not happening, you have to give them some treatment. So such patients, we will immediately start on haloperidol. We start them on haloperidol and we start adjusting the dosage of haloperidol so that their normal function can happen. So we don't want their food and nutrition and hydration to suffer. So this is one thing which we'll have to take care of.
Okay, thank you, sir.
So that is usually when such things happen, we start the pharmacological treatment. We won't wait for non-pharmacological treatment and all those. That will happen hand in hand, but you may have to give the medicines also.
We can put a Ryle's tube.
If you put Ryle's tube, possible if the patient will not break your hand or bite off the tube, something like that. No, I'm just saying because many a times these patients may be agitated, so they are not going to allow you to put the Ryle's tube. Suppose if you put the Ryle's tube somehow and you just turn and to put the micropore, by that time they would have pulled it out again. So many a times these patients in delirium, especially in ICU, you will see that they want to pull out the tubes. And that is one of the main reasons why you want to tie their hands and legs, right? So that they don't pull out the tubes. So that is something which you have to be very careful of. You have to start the treatment with pharmacological management. And after that, still if it is not happening, then you may have to put a Ryle's tube and do those things. One of the other things, instead of tying the hands and leg, what you can do is you give a ball or a cotton or something in their hand or paper,
Okay.
and then you just wrap it with a gauze piece, with a gauze roll, so that they can't do anything, they can't pull out anything, or they can't harm anyone with that. That is also one of the things which is done. It is better than tying the hands and legs.
Okay, thank you, sir. Thank you so much.
Okay, Sister Ji.
Thank you, sir.
Okay, thank you everyone. Thank you everyone for your patient listening. I hope it was a useful session and you got to learn something. All the best for your remaining sessions. Continue
Thank you,
being
sir.
active. Don't be passive in sessions, otherwise it will become boring for you. So be active and keep learning and stay in touch. Thank you
Thank you,
everyone.
Doctor. Thank you.
Thank you so much, Dr. Deepak, for the detailed presentation. Thank you all for joining for today's session. We'll see you on the next session. Bye-bye.
Thank you.